Morning. Good morning. Sorry. Okay. So, one thing that I kind of wanted to bop on and maybe start with because we were, I kind of rushed this at the end. Um, Normally, when I will just be straight up, I mean, I explain where you can hear the different valves and the different sounds. Most of the time, when we go into a physical, I get the heart rate, I feel, and I make sure there's not a pulse deficit. So that's one thing. When you auscultate the heart, you always want to feel a pulse to make sure that they're synchronous. Um, and the other thing is I will just listen, usually maybe in one spot, maybe I will check on both sides, but mostly our job is to, say, is there a murmur, is there not? The veterinarian is going to go in and they are going to be responsible for, diagnosing the murmur or trying to figure out where it's coming from. So I just wanted you to know from a clinical standpoint, it's not our job. Now I'll go to my boss and say, hey, it doesn't sound right. And then they'll go in and they will listen and determine if there is truly a problem. But just letting you know, the lub dub is the sounds of the valves closing. And then normally, in anatomy, I told you the heart lies between ribs 4 and 7. A lot of times that depends on the size of the dog, but in general, you're good, Kristen. In general, that's about where the space is. And just if you slide your stethoscope under the elbow, the point of the olecranon, that's about where the heart should be. And in cats, it's a little more caudal. So that's about, and you're always going to listen more ventral. This slide, you do not need to know, but it's telling you if you were looking for an issue with which valve, where would you position your stethoscope? And the other thing, clinically, sometimes there's dogs that are crazy and panting. Sometimes you have, yes, sorry, Caitlin Starks, so, I just want you to know that if you get really good at listening to the heart, you can listen in different spots and find out where the murmur is. But mostly our job is to go in, get the heart rate, listen. And that's the issue that we have. Okay, so again, this is showing you, but remember, I do want you to know the heart is more to the left. The apex is pointed caudally. It's not supposed to be straight up and down. Now, right here, I do not need you also to know where they are. So we're not going to go over that. So when you hear a murmur, it is literally that turbulent blood flow. That is what causes the sound. The valve can have a couple different issues. I did talk in anatomy. If you remember, it's like a gate and it should open and shut very tight. If for some reason you have one that's weak, this valve could be fine, this side, and then this side is kind of like that little, your gate that moves in the wind. It's letting blood backwards. It's supposed to stop that. It could also be where the gate is narrow. Instead of opening like this, it might open like this. Okay, now what happens is when the blood is trying to push from the upper chamber, it's trying to squeeze through a smaller narrow opening, and that allows some blood to be pushed backwards. So it can be leaky, it can be narrow, and then they're going to have to try and find the issue. So if we go here, sometimes we'll call the disease valvular insufficiency, which is really a leaky valve. And what's happening is it's not completely closing. Okay, that's the one that's kind of going like this. So we call it, and I will tell you, one diagnosed issue is mitral insufficiency. And mitral insufficiency means the mitral valve is leaking. It could be narrowing, and that is what we call stenosis. That is because the opening is not opening all the way, and it's causing a turbulent past the opening and or anywhere near that opening. When I worked at Purdue, we had a study. We did open heart surgery on dogs, and this was a long, long time ago. But we had dogs, if they had what's called subaortic stenosis, the doctor would go in and try to cut away or open up that valve. Nowadays, they can do that with like a balloon procedure. They put in a catheter and they'll inflate a balloon and try to stretch out that valve for stenosis. When we were there, we would go in and into that valve, and the doctor would try to cut it away, which is a very risky surgery. You're talking about opening the aorta. Okay, so, but I want you to know the difference between insufficiency and stenosis. Stenosis is a narrowing. For example, pugs have something called stenotic nares, where the opening to their nasal cavity is stenosed or narrowed, and we will go in and make little cuts, and we can surgically open their nostrils so that they can breathe better. So a lot of brachycephalics have what's called stenotic nares. So anytime you hear the word stenosis or stenotic, it's pertaining to something that's narrowed. So it doesn't just mean the heart. There's other areas. Sometimes there is a systolic murmur, and sometimes there's a diastolic murmur. And again, stenosis is when, or systolic is when we have contraction. Diastole is when we have relaxation. So if you have AV valves should be fully closed when the aortic valves and the pulmonic valves open. Because remember, what's happening here is the atria contract, push the blood to the ventricle, and then the ventricle contracts and pushes it out the pulmonary artery or the aorta. So all of that's supposed to be happening at different times during the cycle. So what you're saying here is the AV valves, which is the mitral and the tricuspid, should be closed when the aortic and pulmonic valves are open. And that means the ventricle's pumping out. They don't want more blood coming in. And then the diastolic is when the aortic and pulmonic are closed and the AVs are open. Okay. So aortic and pulmonic insufficiency are rare. I would say the two main stenosis surgeries we did at Purdue were pulmonic stenosis and subaortic stenosis. So most often the stenosis has to do with the valves at the major arteries, not necessarily in the valve. And then the left AV insufficiency, which is the mitral valve, is the most common to have insufficiencies or be leaky. And I will say, sometimes you will pick it up in older dogs, and people had no idea that their dog had a murmur. My cat has a murmur, and one day I just found my stethoscope, and I was like, oh, come here, animals, and I listened, and he's got a nice little murmur, and I had no idea, like he doesn't act strange or whatnot. So sometimes you pick up these murmurs, and these animals can compensate, but we'll get into the diseases in a little bit. Now, there are other murmurs that can be picked up that do not have to do with the valves. If an animal has what's called a PDA, which was the patent ductus arteriosus, and maybe you remember that from anatomy, it's when the ductus does not close after birth. So a PDA is a young patient disease. We're not going to see a 10-year-old dog and diagnose a PDA, because a puppy with a PDA is not going to make it very long, maybe 4-6 months old potentially. So if you see what I'm saying, if I asked you about a PDA, one thing I'm stressing here is age, because this is a young puppy disease. But their heart's going to sound like a washing machine. It's not even going to be faint. You're just going to hear a lot of swooshing. And it is continuous. If we look, and maybe you remember this picture from anatomy, it's from the anatomy book. During in utero is the one on the left that I'm pointing at, is remember when this is the pulmonary artery, okay? Normally the pulmonary artery takes blood to the lungs, but remember in the fetus, they are not using their lungs. They are relying on the mother for circulation. So what happens is it has an opening here, which is called a ductus arteriosus. And that blood it gives a little bit. Do you see how it splits? It gives a little bit of blood to the lungs, enough to let them grow. And then the majority of the blood keeps moving into circulation. After they're born and they take their first breath, and this should happen fairly quickly, is basically they're cut from the umbilical cord, and then right here, that ductus will seal, and now that blood is forced to the lungs. If for some reason in a puppy, if that remains open, you can imagine that the blood flow is not enough is going to the lungs. So you have to think in your head, what is the consequence of that? If for some reason not all the blood supply is going to the lungs, they're going to oxygenate poorly. Usually these puppies are called poor doers. And sometimes they're like, oh, he's the runt. Oh, he's just really tired. Oh, he just never ate well. Well, it could, you have to listen to the heart. If it sounds like a washing machine, these puppies aren't going to grow well. They're not going to feel good. They're going to feel nauseous. They're not going to want to play because they're going to get tired. They might even look cyanotic. So the nice thing about this, if you have a surgeon willing, there are surgeons, we did this surgery at Purdue. This isn't like a regular vet kind of surgery, but because they're very critical during surgery, is they will go in, this is outside the heart. Okay, so this isn't an open heart surgery. This right here will be tied off. And then all of a sudden the blood gets forced. And like I said, it's super cool during surgery because we would have a bunch of students in the room at Purdue. Usually their pulse oximeters, their oxygen levels were really, really low while we were doing the operation. And I told everybody, I said, now watch. As soon as the doctor tied that, the blood went to the lungs, all of a sudden oxygenation goes up, heart rate comes down to normal, and it's pretty much like that, okay? So again, this is a repairable condition. It's outside the heart, but it can happen in these puppies that are poor doers. But this is a young dog disease. What would be a little bit worse is if you had an atrial septal defect or a ventral septal defect. So let me go back to the picture. Is right here, this is the atrial septum, this is the ventricular septum. That should close. If they don't, this is the babies that have a hole in their heart. If they are born with a hole in their heart, what it means is that probably this foramen ovale or oval foramen did not close. And so it allows blood to go from the atrium laterally. Okay, so you're not supposed to share blood between right atrium and left atrium, because then you're mixing oxygenated and deoxygenated blood, and it's not going properly through the circulation. This would be a very critical surgery. I have never been involved in one of these surgeries, in babies, they do this. But in most of these guys, they would probably be euthanized if we found this in a puppy. But the PDA is fixable. So you can have it most often the atrial septal, sorry, my internet's being weird. Okay. Most often the atrial septal defect is the issue. So any questions on the basic parts of the heart or any of the okay. So we're just going to add on a little bit of respiratory anatomy review. So we want to get into the diseases. If we look, if you remember, there used to be an image that I put on the test, the respiratory system test, and it was the side of the dog's head, but you have the larynx and the pharynx. And one of the questions I asked on the discussion board the other day was, what structure is protective of the trachea? Which the trachea is just caudal to the larynx. So the larynx is made up of different cartilages and different structures. So within the larynx, you have the arytenoid cartilages, the arytenoid muscles, the vocal folds, and the epiglottis. So within that structure, now the vocal folds, I don't know if you remember from the picture, you got vocal folds. They're attached to cartilage, which is attached to the arytenoid muscles. So when the animal inhales, those structures pull open. It'll make the vocal cords really tight, okay, but and then it will close, or they'll inhale, and as they exhale, inhale, exhale, they'll start to open and close. Now, the epiglottis acts like a flap. Now, when the animal eats and drinks, that epiglottis should cover the larynx so that they don't inhale any food or water in their trachea. So it's open when they're breathing, it closes. So the larynx is the protective structure, primarily the arytenoid cartilages and the epiglottis. The pharynx is like the back of the throat, and that's the common passageway for food and air, or food and water and air. So digestive, it has digestive and respiratory functions. So the pharynx is back, but the larynx, remember my little thing in anatomy, pharynx, food, first. The pharynx comes first before the larynx. Food can pass through it. Okay, the larynx is caudal to the pharynx. But only the larynx has the protective structures. And then the glottis is that opening. The epiglottis is above, epi above. So the epiglottis is attached to the glottis. And then once air goes in, if you remember, the trachea is going to bifurcate. Let me show you on this picture. So you up here, it's not on this picture, you would have the larynx. Okay, you'd have those protective structures. Once the air goes in, the bifurcation is right here. And the bifurcation is where the trachea splits to the right and left sides of the lungs. Now, since anesthesia will be coming up for you guys, when we intubate an animal, a lot of those endotracheal tubes are very long. Dogs have very different lengths of neck size. Okay, cats, all about the same. But dogs, you have a greyhound and then you have a bulldog. Okay. When you feel right here, if you palpate, now not on an awake dog, most, unless they're super chill, aren't going to let you palpate here. But when we intubate, we reach in here and we grab the trachea, which is a rigid structure, and we hold on to it. And then I tell you to slide the tube a little bit back and forth, not like crazy. We're not trying to rotor-rooter the trachea. I just want you to slide it, and you should feel the tip right at the thoracic inlet. I don't care how much tube is hanging out. I mean, I'll get into that in anesthesia. What's more important is that you don't shove the tube all the way in till the tip is at the mouth, because it can go down one of these sides. Then you're only providing oxygen and anesthetic to one side of the lungs. So the bifurcation is an important landmark, especially when we talk about intubation, is making sure your tube does not go too far. The other thing to remember is, it's not on this picture, the esophagus lies right along the trachea. So, you know, when we talk about intubation, I will talk about, how do we know the tube is in the right place? How do we know it isn't in the esophagus? Because it's very easy to put it in the esophagus by accident. So we'll talk about that. Let me go back to the mediastinum is the area between the lungs and the thoracic cavity. So the mediastinum is on the median, but it is where you find the heart, the blood vessels, the nerves. Most of the dorsal, caudal, thoracic cavity is all lungs. So most of the important structures are in this mediastinum. There's a cluster of lymph nodes. It's where the thymus gland was located. So dogs will sometimes get something called a pneumomediastinum. Yeah, Haley, all I said about ventral septal defect was it's basically called a hole in the heart. It's diagnosed in very, very young puppies, but usually we euthanize, unfortunately. The PDAs can be fixed because they're outside the heart, so it's less critical surgery. Okay, so the mediastinum, if we say a dog has a pneumomediastinum, it means that the dog has a pneumothorax, which is air outside the lungs, but it's located in that mediastinum, which is the ventral cranial chest. So it's a very important area that we talk about on a fairly regular basis. You'll hear us refer to that area. The left lung typically has 2 right, most animals 4 to 5. Now the horse has 5, 2 and 3. All I want you to know is there's multiple lung lobes, okay? So a dog can have, so if we look at this next picture, excuse me, on the left, you can have a cranial and a caudal lobe. On the right, you can have a cranial middle, cranial apical, which is more towards the apex, middle, sometimes they call it the cardiac lobe, most people call it the middle, and then you'll have a diaphragmatic or a caudal lobe, and then they'll have like this extra lobe. And the interesting thing is, they can have an injury to a lung, they can have a tumor in a lung, you can remove a lung lobe. Because obviously they have other lobes that can, take the load. So there is sometimes issues where we will remove a lung lobe, sometimes due to trauma, sometimes due to cancer. Now, some things to remember about the thorax. The lining is called the pleura. So it is what the pleura does. And if you remember when I talked about linings, they're like wallpaper. They cover the wall. The other thing the pleura does is it will cover parts of the organs. So the visceral side is what we see. If you open the thorax and we look at the wall, that's the pleura, or that's the visceral pleura. The parietal pleura is what is attached to the wall itself. So if you pulled off the pleura, you would have muscles and connective tissue under there. The pleura is going to make a fluid, just like the peritoneum in the abdomen makes a fluid, just like the pericardium of the heart makes a fluid. Those linings create a lubricating fluid. So there is a little bit of fluid in the chest. There is a little bit of fluid in the abdomen. So again, the parietal pleura lines the walls. The pulmonary visceral pleura is this. Now, serosa is a type of tissue. Serosa is what produces serosal fluid. Okay, so there is serosa in the intestine. Any area that produces this fluid is called a serosa. So serosa is a general term. Pleura is specific to the thorax. Now, pleuritis is inflammation of the pleura, which can come from a lot of different reasons. I talked about, or I don't know if you remember when I talked about, let me type it here so everybody gets it in case. Pleural effusion. Anytime you have an effusion, you have a cavity or a space that has too much fluid in it. So pericardial effusion is too much fluid around the heart. Pleural effusion is too much fluid in the thoracic cavity. Peritoneal effusion is too much fluid in the abdomen. There's a variety of conditions that cause that. And when you guys, and I believe, what Clin lab class are you in at the moment? Are you in Clin lab 3? Oh, you're in 4 right now. Okay. Have you talked about cytology of fluid? You should have already done cytology. Okay. So that's exactly what you have to do. You know, you can find fluid on an x-ray and the owner will say, why is there fluid on my cat's chest? And we will be like, we don't know until we actually take it off of the chest and look at it. If it's straight blood, it means one thing. If it's, you know, chylous, if it's lipemic, if it's purulent, if it's clear. So again, pleural effusion just tells me there's a buildup of fluid. Then I have to get to the reason of the effusion. So hopefully that makes sense. Effusion is just going to tell me there's fluid there. Now, if you have a pneumothorax, that is air in around the lungs. And where is the air supposed to be? Inside the lungs. So the other thing that I would say we need to add on here is well, let me bring that up real quick. If you remember, excess fluid builds up. When we have excess fluid in the body, it's either called edema or effusion. If it's an effusion, it's a buildup in a space, an empty space or a cavity. If you have edema, that's a buildup of fluid, but that's in tissues. So pulmonary edema is fluid inside the lung tissue. If you have edema in your ankles, it's trapped in between the muscles and the fat and the connective tissue. Trying to think of some other. So that's, I want you to know the difference between pulmonary edema and pleural effusion. Both are fluid, excess fluid conditions, but they're in 2 different locations. Now, pneumothorax, again, if you remember, when I talked about respiratory system, we talked about negative thoracic pressure, positive thoracic pressure. The space around the lungs has negative pressure. It's supposed to act like a vacuum. Okay, so when the lungs, when you inhale, that negative pressure sucks the lungs out. Did someone need to unmute a second? Okay. When thorax does this, the lungs expand, air comes in. When the chest collapses, it pushes the lungs and air gets pushed out. So the lungs are passive, air moving in and out. When we have what's called a pneumothorax, somehow air has escaped the lungs, or, well, 2 reasons. It either leaked out of the lung into the space and it starts creating pressure, positive pressure. Then the lungs can't expand. Or say a dog was hit by a car and they fractured a rib and it poked through their thorax. Air can come from here outside in it because the chest is a vacuum. So air goes and sucks into the chest. So a pneumothorax can be internal reasons or a pneumothorax can be external, one or the other. Again, if you see a big gaping wound in the chest, that's why I have a pneumothorax. But sometimes dogs come in and have these silent pneumothorax. And sometimes they have lung disease. Or sometimes they're hit by a car. There's no trauma on the outside, but it caused a contusion imagine the lungs hit the chest cavity, and then the lung forms a bruise, and the dog inhales, and sometimes they pop, or they get these bubbles on their lungs called bulla. And if a respiratory bulla pops, then it's like a air just filling. So again, we do a chest tap, we suck off the air, that allows the lungs to re-expand. So I just want you to remember the difference between the positive chest, negative chest, where the air is supposed to be, positive in the lungs, negative in the space around, allows the lungs to expand and contract. And then the difference in the fluid conditions. Pulmonary edema versus pleural effusion. Okay, and there is, you know, obviously any of this, there's, you know, obviously your anatomy book and your anatomy notes can help you with some of this basic anatomy review, or all of this is, the basics are in chapter 1 and 11 of your common diseases. So at this point, are there any questions?